All right, good morning, everybody. Happy Monday. It's my pleasure this morning to introduce Dr. Andrew Wilkey. So Dr. Wilkey is going to talk today on preoperative anemia in MHI CV patients, incidence, impact, and future opportunities. So Dr. Wilkey actually is an anesthesiologist here at Abbott Northwestern Hospital. He did his medical school and residency at the University of Iowa and did cardiac anesthesia actually at the University of Pennsylvania. He's actually been a general anesthesiologist here for almost 9 years now and is currently the chair of the Abbott Northwestern Transfusion Medicine Committee. On a personal note, Andrew and I were in the St. Thomas Physician Leadership at college together, so I can tell you that he's a great guy and this is something he's quite passionate about, so we're looking forward to the talk. Thanks, Andrew. Thanks for the introduction. So, get this mic turned on correctly, hopefully. And good morning, everybody. You can bear with me a little bit. I rearranged some of my slides just yesterday, so hopefully I'll remember what order I put them in. So, like Mark said, we're going to be talking about pre-op anemia in CV patients and giving some background about anemia, some of the impact that it has both in the general community as well as in surgical patients, and then some things that we can potentially do here. One thing in particular that we can do here to help improve our outcomes. So here are learning objectives, which are printed on the handout, so I won't go through these in any detail. You can just read those. These are generally the topics that we're going to cover this morning. So one thing I'll start out with is that low hemoglobin or anemia in general is not normal. And I'll let you look over these statements here, but the message is, and it's something that we'll cover a couple of times during the talk, is that while anemia may be a marker for disease, it's also independently associated with poor outcomes. So one of the things that I keep running into when I talk to people about this is they say, oh, you know, we can't do anything about this. These patients are just really sick. And I say, yeah, they are really sick, but if we can change their anemia, particularly around the time that they're having surgery, they should get better. They should die less frequently. They should spend less time in the ICU, all those sorts of things. And I've got a couple of examples of studies that have shown that that's the case. So one of the things that we've looked at in the anesthesia department is variation in care delivery. So we've looked at several areas where we want to define variability in care delivery, and these are a number of the places where we've been looking. We have some active programs going. One of the things, and a couple of them actually I'll mention later in the talk, perioperative glucose management and some of the blood conservation strategies and coagulation management. The thing, again, that we want to talk about today is preoperative anemia. So I don't want to be too pedantic about this, but I think it's important to go back and talk about what is anemia and how it's defined. So in 1968, WHO put together a group and they came up with a definition. Less than 13 grams for men, less than 12 for women. The interesting thing about this definition is that this is based on about 800 patients in 6 different studies that were conducted in different places in the world. Since then, there have been a couple of other studies that were conducted, both in the United States, using upwards of 70,000 patients that covered both pediatric patients, patients in midlife, elderly patients, obviously men, women, minorities, that sort of thing. They came up with some different definitions of anemia that are summarized here. It appears that a couple of these differences, if we just look at white men, and even if we just focus on those that are 60 plus, and unfortunately I don't have a curve to show how this works out, but that difference between 13 and 13.2, if you were to move normal up to 13.2 for those 60 plus men, you end up including actually a pretty large segment that would otherwise be considered not anemic, and they move into the anemic category, which then potentially can impact their care and their outcomes further on down the road, as we'll see with some of these other examples. Unfortunately, most studies and most institutions don't use these definitions, despite the fact that they're arguably based on more robust data, merely from the fact that it's, you know, many times more patients that they've looked at. So causes of anemia, there are three major categories: nutritional deficiency, including iron, folate, and B12 deficiency, which often can be as a result of simply not getting enough in your diet or from occult blood loss. These are our favorite things here: bleeding colon, which I'm sure is seen quite often in some cardiac patients as they're getting worked up for some of these things. It's maybe underestimated as a cause, partly because often you get anemic patients that show up to the operating room and they're duly noted. Here's their hemoglobin, it's 11. Okay, let's go to the operating room. There's not necessarily a lot of additional workup that's done, and certainly not a formalized process for that. So chronic disease, chronic kidney disease, arthritis, diabetes, which some have suggested you should actually call this anemia of chronic inflammation, because the key is the inflammation component. That again, hepcidin something or other, I thought that was kind of interesting, but I stuck it in, but kind of skipped over it in my own mind. But just keeping in mind that this is one of those categories that will fall in with chronic kidney disease, which is one of the major problems that we see in our cardiac patients. Then unexplained anemia, which largely seems to fall under the category of myelodysplastic syndrome. And certainly when you get to patients in the age group that we're looking at, 65 and older, this becomes a more and more important category of anemia cause. So here's a nice graph just showing that as the number of comorbid conditions, which include asthma, arthritis, hypertension, and so on at the bottom, as those go up, both the anemias of chronic inflammation and unknown anemia correspondingly go up, with the exception of that number one there that's a little bit out. I'm not sure why, but it's a pretty nice curve heading up there. So what is the prevalence of anemia then? I mean, it happens. We have an idea of why it happens. So when you look at rates of anemia, you get relatively wide rates. Some of that has to do with the definition that's used, whether or not they use WHO definitions, which populations they use, and just in general the severity of disease in those populations. Most studies show higher rates in men than women, and partly that's attributed to having a higher threshold for men to start with. And not surprisingly, the incidence of anemia rises with age. As we've seen, as people get sicker, their incidence of anemia of chronic inflammation and unknown anemia goes up. And those comorbid conditions that go along with that then, of course, tend to go up as well as you get older. So what is the severity of the anemia then? If it's relatively prevalent, especially in the age groups that we're generally dealing with in the heart hospital, it tends to be mild. Hemoglobin is usually above 10, but somewhere below the cutoffs of either 13 or 12 for men or women. So then again, looking at NHANES 3, which is the study, I believe it had 40,000 something patients in it. So you only had less than 10% of patients above 65 with hemoglobin less than 10. So if that's the case, well, if it's not that severe, then, you know, is it really that big a deal? So looking at it from a public health standpoint and a population standpoint, if you look at the rate of anemia, which in one of the studies that I cited on a previous slide is a little more than 10.5%, you multiply that by the number of people who are going to be over age 65 at each one of these decades, we've got, you know, close to 6, 7.5, 8.5, and over 9 million people just in the United States who will fall into an anemic category. So this is something that affects a lot of people now and is going to get only more prevalent, or I would say worse, as time goes by. So one of the things that we want to think about is that, and one of the problems with some of the studies that have been done in the past is that they haven't been set up to establish causality between anemia and outcome. And even with some of these things I'll talk about later, there's a little bit of extrapolation that you need to do because they don't specifically address that issue. So it is, of course, plausible to suggest that anemia can cause problems that can lead to their own bad outcomes. Now, there are some studies, and I think we got a slide coming up next, that shows as your hemoglobin goes down and as it goes up and you get above 15, you're going to get worse outcomes. So here we've got women. This doesn't project super great because it's a little small. It's about as big as I could get it on this slide. But we got women at the top. We got hemoglobin here that's 14. So hazard ratio for all-cause mortality when you're 14 is less. It gets worse as you go up. But even when you get to 13, you got, your hazard ratio is just 1 at 13. And when you reach the normal for women in this study, you're actually worse off than you would be if you were a little less than the anemic cutoff. And a similar thing then you can see for men. 14 here, you're doing okay. 13, your error bars kind of touch the hazard ratio of 1. But you're certainly tending towards doing worse even when you're looking at just being in the normal range. So we got anemia is associated with the risk of death, almost 2 times higher in this study from Holland. And after they had adjusted for all these different factors, comorbidities, income, education, creatinine clearance, CRP, they continued to show increased risk of death. So this is the kind of thing I'm talking about. Yeah, it may be a marker for severity of disease, but at the same time, we take out all these things that may relate to that, and people still have an increased risk of dying just from their anemia. So this is the kind of the first time that we'll talk about that this is independent of how sick they are to start with. So talking about physical strength and mobility, people do worse if they're anemic. Mental function, their likelihood that they're going to end up having dementia and dementia earlier is greater if you've got anemia. And these are things that we worry about less in the heart hospital. We generally think about things like renal failure and death. Those are things that repeat in our heads all the time. But these are things, this anemia and its effects are something that is widespread. So if we look at this, this is just a nice graph. I liked it partly because it had some color, but it also really nicely illustrates that these anemic patients, when you get out, they end up being demented earlier and more severely than people without anemia. So getting to the mortality part, the thing that we think about, the thing that is looked at both by the hospital, by the government, by STS. So just looking at women who have disabilities in the community, over 65 years old, so once they get lower than a hemoglobin of 11, the risk of dying goes up. If they're a little bit higher, and again, 13 and 14, higher than the cutoff for what's considered anemic in women, they actually do better. So when you got, so this is where women are considered anemic, below 12. But if you look, if they're 13 and 14, they actually do better. It's not a straight line that goes out here. Once we get to be 12, everything's fine. So, looking at 12 and thinking that that's okay is probably okay. It's certainly better than 9, but maybe it's really not as good as 13 or 14, which may be something that's optimistic to shoot for if you're treating these people, particularly if they have a bunch of other comorbidities. But it's something to keep in mind that if you can keep people a bit above that lower end of normal, they're likely to do better when it comes to mortality outcomes. So let's talk about surgical patients. Since people in the community are people obviously we care about because we take care of them, they eventually become our patients. But if we look at specifically a large number of patients, these are non-cardiac, non-neurosurgical patients, had a relatively high incidence of anemia in these patients. We're looking at in-hospital mortality with moderate anemia, odds ratio of almost 2 that they're going to die versus non-anemic. Severe anemia, odds ratio is close to 3. In addition, hospital length of stay, post-op ICU admission were greater in those patients. So when we look at this kind of thing, this is the thing that gets your attention because, boy, they're not going to do as well. And this is the kind of thing that's going to get the hospital's attention. Is, boy, they're going to be here longer. They're going to cost more money, and they're going to do worse. So again, looking at some of these patients, my one funny looking slide, I think. So looking at colon and rectal surgery patients, we see again that we've got an increasing severity of, or increasing likelihood of death with increasing anemia. So, and again, this kind of thing I threw in just because it is of interest. So, and in this study, they were looking at correcting for cardiovascular disease. It didn't make any, well, I wouldn't say it didn't make any. Once they took that out, people still did worse. So again, kind of getting back to this theme of, you know, is it a marker of disease or is it actually something that affects outcome? In this case, when you take out cardiovascular disease, it's something that affects outcome. Not to belabor the general surgery patients too much, but again, looking at a large number of patients, you've got increasing severity or increasing likelihood of morbidity and mortality with increasing severity of anemia. So I think I probably talked about that enough. This is actually a really nice graph that relates to that last slide. So here we've got no anemia and no factor, meaning cardiac disease, COPD, CNS disease, that sort of thing. Then in the orange, we've got either the disease or anemia, and then in the blue, we've got both. So you add anemia onto these things, it makes it look like an independent risk factor. So talking about vascular surgery patients, it's nice to see Dr. Titus in the audience today, one of our vascular surgery people. So looked at a bunch of patients from NISQIP. So looking at primary and secondary outcomes, 30-day mortality and composite endpoints, either cardiac arrest or MI, 47% anemic patients. So you've got 2.4 and 2.3 for morbidity and mortality versus 1.1 and 1.2% in non-anemic patients, which ended up being statistically quite significant. Again, looking at about 400 vascular surgery patients in a different study, about a third fell into each of either mild, moderate, or severe categories. Then looking at 30-day and 5-year major adverse cardiac events. So you see again this trend towards likelihood of having that adverse outcome as your anemia gets worse, both in the 30-day and in the 5-year. They noted in this study that transfusion probably increases surgical site infection and late death. So the nice slide from that, you get a transfusion, things get a lot worse for you even over 30 days. So moving on to cardiac, which is where many of us spend a lot of our time, people specifically with heart disease. It's where I spend most of my time. So currently, anemia isn't a factor that's figured in STS risk and mortality calculations. And if you actually look at the STS website, they acknowledge that anemia negatively impacts heart surgery outcomes. It's on this page here, and they specifically cite this study by Marco Ranucci from Italy about that. So looked at almost 14,000 patients, had 400 patients with severe anemia, put in a control group for non-anemic or non-severely anemic patients. Anemic patients, rate of stroke was higher, major morbidity was higher, operative mortality was higher. So this is something that obviously is on the STS's mind, and yet they've not seen fit to figure that into the risk calculation. Interesting to see if they will, though, eventually. This is a graph from that, so showing you've got these severely anemic patients have bad outcomes, but even when you look at moderately anemic patients, they have similarly poor outcomes. So another study looking at close to 8,000 patients. You've got 1,800 that are anemic, 6,000 or so that are not anemic. You get triple the risk of death, and triple the risk of renal dysfunction in these patients if they're anemic. Additionally, risk of post-op stroke, AFib, and long hospital length of stay are all increased in anemic patients. Again, I could drown you guys in studies, but I tried to hold it to about 3 per. So this is Kevon Karkouti from Toronto, looked at 3,500 patients at 7 hospitals across Ontario, looking at in-hospital death, stroke, or acute kidney injury. You had people used a kind of an average cutoff of 12.5 for hemoglobin. Ended up 7.5% of the people ended up with some sort of one of these outcomes, death, stroke, or kidney injury. So even with risk-adjusted, both in multivariable and propensity-matched models, although that was better than the unadjusted, you still showed approximately 2 times greater risk of poor outcome. Here's a graph from that study that this is the unadjusted one. I suspect that they put this one in because it looked that much more impressive, because you get a big sweep up here as you get in below that 12.5 into the anemic range. And in any case, I think if they'd put in one of the others, it would still be pretty clear. So anemia is bad. It happens a lot. It hurts people. So what about here? What happens in MHI? Because I can show you studies from all kinds of places. And the common response I get is, well, yeah, this is Abbott. We're different. We do things better here. So we looked at we looked at all the cardiac surgery patients from the beginning of 2014 to the end of September last year. We found that of the elective patients, 23% had anemia. If you look at all patients, which would then include urgent and emergent cases, which we took out because we didn't think that we would have a reasonable window to get these people's anemia treated, although there's some idea that some of those urgent patients, potentially, if you could delay their surgery and treat some of their anemia, you may be able to impact them. But we stuck with electives because it seemed clearer. This is kind of how it broke down. And it's interesting that we've got AV, MV replacement, 40%, the greatest percentage of these people who ended up having anemia. This is one of these times, and again, I've gotten the response, oh, these people are just really sick. I would agree, people with double valve disease are sicker than those people who are coming in just to have a cab. But I would also argue that those are the very patients that we should be looking at more carefully so that we can optimize their hemoglobin. Because it's clear that even though that may be part of a marker of their disease, that by just leaving it alone, they're not going to do as well. And particularly with elective patients and patients who have been watched for a long time, as many of these valve patients are, we've got the time to be able to take care of this kind of thing and at least evaluate and try to treat what appears to be the cause of their anemia. And it's true that some people we won't be able to fix. But without making some sort of effort, we'll never know, and we'll never have an opportunity to improve their outcomes. So when we look at complications in the same group of patients, any complication, not a huge difference. That didn't reach statistical significance. Intubation, median initial ICU, none of that significant. And even from a financial standpoint, a 3-hour difference here and less than 1 hour difference here may not make any kind of difference. Renal failure, more severe in anemic patients. Again, some of these people may have renal insufficiency to start with, but we don't have a formalized process for running these people through, so we don't know what we could do to help them. So, significantly, death. At first I had this bold-faced and italicized, but I thought that was a little much. But, again, anemic patients die more than 3 times more frequently than patients without anemia. And again, we see this AV replace, MV replace, a third of those patients who are anemic die. Not anemic, none of them die. I think it's difficult to attribute all of this 1/3 of deaths to them just being pretty sick. These people here were pretty sick, but they didn't have anemia and they didn't die. You may note that here, cab only dead. Probably I didn't actually do the P, but I don't think it's significant, partly because the number of straight cabs we do, it's really small. It's usually combinations, or then they fall into, oh, they got the cab and they had a PFO closure, and that drops them out of that category. Or somebody tied off their left atrial appendage, that drops them out and puts them into other 8% versus 0.9. So again, worse off if you're anemic. So cost, you go through all the 9 breakdown categories in the STS database. Anemic patients are more expensive throughout each one of them. There's no savings anywhere for these people. And on average, again, out of the same group of people, it's about $2,500 per patient that they cost over those patients who aren't anemic, which at some point starts to add up. So the solution that I hear sometimes is, oh, we'll just give them some blood pre-op. So another nice study, and I've got a really nice graph for this one. It's very colorful. 3,000 patients looking at survival at 3 years, as well as length of stay in hospital mortality. Guess what? It's worse if you're anemic. It's worse. It's even more worser if you're anemic and you get blood. So this is, the slide's a little busy. There are a couple that break this down, but I like this one because it fit everything into one thing here. So here, not anemic in the solid green. You go to the broken green, these are not anemic and got a transfusion. That's the same thing as being mildly anemic as far as outcome goes. Same thing happens then in each category. So you've got mild anemia, give them blood, they get worse. Severe anemia, boy, severe anemia is a lot worse than no anemia. Then you give them blood, they do worse. In-hospital mortality, length of stay, all that. So the solution of, oh, we'll just tank them up with something ahead of time. If they're elective, why would you do that? True, you need some time to evaluate and treat anemia. But again, we're talking about elective. Not urgent, not unstable angina. Had a guy last week, unstable angina, needed a 2-vessel bypass. Had a hemoglobin of 7.5. Okay, you get some blood and go to the OR because you can't go home. But a lot of these patients, we have the opportunity to be able to impact their hemoglobin. That brings me kind of to what can we do about this kind of thing? So there's a concept called patient blood management that's got 3 pillars that go along with it. Detection and treatment of perioperative anemia, reduce perioperative bleeding and coagulopathy, which is another one of the things that's close to my heart and is like a whole other talk that I won't subject you to now. And harnessing the physiological tolerance to anemia, which is just kind of optimizing as much as you can. You know, making sure the kidneys work, get them their inhalers, all that sort of thing. This is the one that feels like holding hands and humming to me a little bit. But there are some things that you can do. But these things have very easily measurable things that we can look at, and there are discrete interventions that we can do to affect these things. So, detection and treatment of perioperative anemia. So this is work that's been done a lot in orthopedic surgery, a little bit in spine surgery. And there's this kind of idea around cardiac surgery, but there aren't a lot of places that do this kind of thing. There are a few in the United States. There's a province-wide effort in Ontario to better manage blood. So these are some of the things that are recommended by this, the Network for Advanced Transfusion Alternatives, looking specifically at ortho. So treat nutritional deficiencies, EPO for anemic patients. So There's an idea. How about looking at EPO? Oh, and this was, I won't, again, belabor all this stuff. This is all evidence-based. I didn't put in all the references, but it's an interesting paper. So you look at EPO, give some people EPO, you give them iron at the same time because giving EPO without iron doesn't work so well. Primary endpoint was looking at transfusion during surgery and for the first 4 days post-op. People got less transfusions. We've already seen that giving transfusions to people is bad, whether you're anemic or not. And by moving these people closer to not being anemic, even if you didn't make it all the way there, their outcomes should be better. Oh, and this one, there was only 74 patients. They stopped it because the IRB was unsatisfied with the outcome of the patients who weren't getting their EPO and iron. So now everybody had to get EPO and iron. So again, looking at EPO, ended up with post-op morbidity, mortality, renal failure, transfusion, and hospital length of stay, all better by giving EPO and iron for 4 weeks at a time. So how do we do this kind of thing? One of the things that we've worked on here and is evident from looking at quite a bit of literature, and I just put this list up here just to show that this took me 5 minutes to just find these and put them up here. Using algorithms to standardize care or reduce variation in care is something that will improve patient outcomes every time. One of the keys to the success of this is not only having an algorithm that then standardizes care, but to have a mechanism by which then you look back and say, okay, well, where's the gap? Where did this work? What do we need to do in the meantime to try to make this better? Just slapping one up there and hoping everything's going to get better, it'll make things a little better. But having a process where you can iterate this and keep going back and saying we want to improve and improve and improve is part of the key. So we have precedent for this at MHI within the anesthesia department. This is a graph from the perioperative glucose management project that we started a couple of years ago. We started out with these baseline patients. Mean glucose levels are pretty high in between these different categories of patients, and glucose levels below 180 were relatively low. Went through protocols, I'll point up here, protocol 1, 2, and 3. The specific details of which don't matter that much, but basically we're making the glucose control tighter and tighter and tighter as we went along, more aggressive with the insulin intraoperatively. And as we did that, mean glucose levels came down, glucose levels below 180 went up. During this time, which was, what, over 9 months, something like that, there was one time a patient had hypoglycemia. And that anesthesiologist decided to do it their own way on that patient. The only time we had hypoglycemia. This algorithm we got is a single sheet of paper that's in the operating room that we don't even get called about this anymore. The CRNAs go, oh, it's above, I think it's 130. They look back on the thing and they start the insulin. Every time they get a new value, they go back to it and say, well, what do we do now? It's been a great thing. And obviously, improving glucose control is better for people. Another thing that we've been looking at is the effect of rotational thromboelastography on bleeding and blood product use. So I don't have the time period on here. This is about a year ago is when I went back and looked at this. So this is CAB only, blood product utilization, intra-op, post-op, reductions in basically everything except cryo, which you see went up slightly in both categories. That has to do with the algorithm that we use that emphasizes the correction of hypofibrinogenemia, since that tends to be the first thing that goes for patients who are going to bleed. But everything else we've used a lot less of. And this is algorithm-based. We're on algorithm 2.0. The first one worked pretty well. The second one's much better because the first one, in retrospect, was awful. So, is there a precedent for doing something like this to take care of anemic patients before cardiac surgery? As a matter of fact, there is. This is a program that was started at Duke and is recently described just last year in the journal Transfusion, Perioperative Enhancement Team. And these are the steps that they went through in order to make their program happen, where they've been able to not only help control anemia in their pre-op patients, but a bunch of other things, optimizing renal function, that sort of thing. But this was the focus of this paper. So taking a look at this, there are a few things that we picked out as things to do first as an effort towards pre-op anemia clinic. So first thing we want to do is come up with an institutional rationalization. So I think that we've done that. We've got anemia in elective cardiac surgery that's not being addressed in a formal manner. We've got poor outcomes demonstrated not only by studies elsewhere, but by what happens to our patients here, as well as having increased cost. So all those things would be reasons to take a look at this and try to change it. So determining a target population, again, looking at currently what fall into the category of elective patients is probably the way to go. We don't want to rock the boat too much. I don't think that surgeons are going to take kindly to us saying, yeah, this guy I know, and he's got to wait for a month. We want to try to catch those patients who are going through the valve clinic, who are going to be there well more than a month ahead of time, and figure out, hey, can we screen these people and try to figure out if they're anemic to start with. If they're not, hallelujah. If you need surgery, let's go. If you are anemic, there's enough lead time from being able to see them in the valve clinic to the time they get their consult with the surgeon to the time they go to the operating room. Yeah, time to screen and treat. So we want to develop an institution-specific treatment algorithm. I talked with Josh Mueller from the pre-op clinic. This is his estimation of what would work as far as workflow goes. He's working on vetting this through HEMONC, making sure there's nothing else that somehow he's missing, although it looks pretty good. So and then designing clinical workflow, kind of working on a pilot within a pilot right now, is trying to figure out how we're going to get these people's blood drawn, the test done, run through the algorithm. If you need stuff done, how are we going to get you to the infusion center, get your iron in you, get you your EPO if you need it. If you live in Devil's Lake, North Dakota, how are we going to handle that if you're coming back here and you're going to have your double valve? So we're going to look at about 10 patients coming in just to work out those kinds of kinks. How do we get them screened? How do we make the decision to treat, and then where do we send them? And how do we educate them about the importance of doing this kind of thing? Because we can't just say, oh, we want you to go to an infusion center every day for a week. Enjoy yourself. So there's also a patient education part that will go along with this. So other things that we need to do, talking about institutional thresholds for transfusion. We've got that generally for the hospital. If you don't have ACS, the threshold's 7, hemoglobin is 7. If you do, it's 8. And yet, when it comes to being in the operating room and for post-op, that's certainly much looser. That would be some work to do later on down the road. And that's an area where we definitely want to have a system in place where we can frequently look back at patients and make sure that, particularly if we're using a more restrictive transfusion plan, that we're not actually hurting people. That's part of the importance of this backwards-looking iterative process. Rather than just slapping something on it and saying, hope it works out. With all these things, we need to be able to look back and make sure they're actually working. Specific financial plan and business case, somebody else is working on that, not me. I mean, I can count, but not that well. And then working on making sure we get integrated clinical and laboratory workflow and EHR, all that sort of thing, especially when we're talking about patients who are coming from elsewhere. That can be a little difficult. Different systems, even within Alina, your paper H&P that comes with the labs on it, and for some reason it's just not coming over. So that's something that we've got our eye on, but I can surf the web and make PowerPoint presentations, but I can't do stuff like that. So I'm glad that it was less than an hour. I took out a bunch of slides because I tend to talk too much. Anybody have any questions?
Thanks a lot for that.
You're welcome.
I have a couple things. One, I'm trying to think about the mechanism, and I think it's hard for me to sort out in my mind. Were they able to correct for transfusions in the large group where you corrected for comorbidities? And trying to understand how much of anemia is an epiphenomena versus how much is the relationship to the therapy we give for it. And then again, how well can you truly correct for comorbidities?
Yeah, and that's the problem with some of these studies. Most of them are retrospective, so I mean, some of these corrections are it's the magic of statistics, although pretty consistently. And in the interest of time, I did leave some studies out. There are some that, again, show just like that other the one with the nice colorful slides where you've got worsening outcomes with transfusion versus not with transfusion. That's something that happens over and over again.
So in other words, is it the response to anemia that's creating the bad outcome as opposed to anemia?
Right. So it turns out it's both. I mean, people will do worse with the anemia, and then when you stack blood on top of that, they get worse almost every time. And again, I didn't want to have everybody fall asleep on me, but it's, yeah.
Did you have any thought about piloting this as a research project instead of a clinical process change? It seems like a lot of the data that you presented was retrospective, like you said, and that there's a little bit of prospective data using the EPO and the iron. But could we validate that original study with a similar study here?
We probably could. There was kind of limited appetite for jumping through the hoops of IRB for something like this, but certainly if there's other interest within MHI to help drive something like that, I think that would be something that we would consider. Yeah, I mean, I'm for that kind of thing. But currently, people were wanting to try to get it off the ground just in terms of trying to improve outcomes. But if you're interested, come talk to me.
Do you have any speculation as to why people receiving transfusions do worse? What is there about the transfusion that causes them to do worse?
Well, it's a tissue transplant, inflammation, trolley, volume overload, and all kinds of different things that can cause problems with that. I mean, actually worsening renal function. Who knows how old the blood is that they're getting, if they're getting the stuff that's at the end of 42 days. That kind of thing. And also, I mean, there's some question about do they always get appropriately transfused? Are they getting the right thing at the right time? So, and some of these things it considers not just red blood cells, but FFP and that sort of thing, which tends to be FFP tends to be over transfused and yet underdosed when it is transfused.
I may have missed it, but is there any data about this active or this very rapid correction with transfusion versus, let's say, a 4 to 6 week run-in? Did Duke or anybody actually publish a comparison? Like, say someone comes in and had actually a run-in of EPO for 6 weeks versus someone who was still anemic. I mean, if you look retrospectively, there must be patients that actually got that, right? Maybe renal transplant patients or something like that. Is there any data that shows that if you do the EPO, that it actually benefits the patient in a retrospective manner? And then the second question would be, do we need to follow these patients for a year and make sure the anemia is corrected for a longer period of time, or is it just that time point of surgery that we are concerned about?
Okay. Well, I'll answer your second question first. It seems that most of all the studies that I read, they correct people up until the time of surgery, and then that's it. Partly because some of the inflammatory changes that come along with surgery make it more difficult to correct with iron alone or iron and EPO because of even when they're given intravenously, the ability of the bone marrow to integrate all this sort of thing and actually make more red cells. So yeah, most of those they just do it through surgery, and you still end up with these kinds of outcomes where people do better. It's just getting them through that acute event. And then your first question, and I think I'm understanding it correctly, but so I didn't run into any studies that looked at people who were treated for, say, weeks beforehand, and then people who were treated right before surgery. There are separate studies that show if you treat people right before surgery, like the day of, you give them a dose of EPO and a dose of iron, and then you give them, I can't remember what the protocol was, but I think it's within either 2 or 4 days, they do get another dose after surgery, they do better than those patients who aren't treated in that way. And that's something that eventually, particularly for urgent or even emergent cases, say, okay, well, can we get this in before they actually go to the operating room? Would that make them better? As a way for those patients who really can't wait, maybe we could improve their outcomes as well. That answer? Okay. Anybody else? No? All right, well, thanks for letting me come and talk. It's fun. If anybody has any other questions, certainly let me know, and I'll get a PDF copy of this to Jolene if anybody wants to look at it. There you go. No hot mic moment for me. No. Wait a minute. That one's off too. All off. Okay. I was just trying to pull, I don't know, whoever that is. Let's see, I need to check. Oh, or just, is it ready?